It was just a normal day. I was in Miami night before a game, feeling some discomfort, but just went on. I worked the next day, perceived to be food poisoning, and it went on for about 2 weeks. My wife was like, you need to go to the doctor and see what's going on. He did the blood work, and everything checked out fine, except there was one number, my alkaline number was over 300. The morning I was scheduled to fly to Chicago, the imagers found a series of blood clots. We need you to either come back here to the hospital or we'll send an ambulance for you. And I said, hey, what's going on? And she was like, you have stage 4 pancreatic cancer. And, it was crazy because the first thing I thought about was, wait a minute, I can't leave my kids. And I started chemo like a couple of days later. You got to be a little bullish and stubborn to get to the next step. The longest path of my journey has been from my mind to my heart, allowing people to help you and not make it about you. To have some great support and people in my life has given me an opportunity to be here. When I called my immediate boss to say, I want to get back to work, I'm probably the happiest guy to be in that replay center ever. It really taught me to enjoy each day as it's given to me. What Lustgarten is doing is help with early detection. I'm hopeful that each day that there are more solutions. Even me sitting here talking to you today, I hope this gives someone an opportunity to know that you don't have to be fearful of the diagnosis.
Good evening, everyone. I'm Linda Tintawi, CEO of the Lustgarten Foundation, and I'm pleased to welcome you to today's LustgartenLIVE celebrating Juneteenth. As the world's leading pancreatic cancer research organization, the foundation believes that everyone needs a seat at the table to help us achieve our mission of transforming pancreatic cancer into a curable disease. Lustgarten is supporting work to make clinical trials more inclusive, which you will learn more about today. We strongly advocate for expanding and diversifying the research talent pool to catalyze the development of new therapies for all patients. Great progress is being made, but so much more needs to happen to truly achieve health equity, accessibility, and diversity. None of our work would be possible without your interest and your support. This includes today's sponsored Northwell Health Cancer Institute. Our thanks to Northwell. We are grateful for your investment in our work. But before we begin, we encourage your questions, so please type them in the Q&A box at the bottom of your screen, and we will answer them throughout today's symposium. Today's live stream event will be available shortly on lustgarten.org/live. You will also receive a survey after today's symposium, which we hope you will complete so we can make upcoming LustgartenLIVE events even more impactful and meaningful. Before we begin, I'd like to provide you with some background information on pancreatic cancer and Black Americans. The incidence of pancreatic cancer is higher in Black Americans than in any other racial group in the United States. Many studies have been conducted to determine the reason behind this, which have suggested environmental and socioeconomic factors to be some of the strongest drivers creating inequities in access to healthcare, along with increased rates of diabetes, pancreatitis, and obesity. Due to these factors, Black Americans are often diagnosed with advanced inoperable pancreatic cancer, leaving them with fewer treatment options. When pancreatic cancer is detected early, Black Americans are also less likely to undergo evaluation by a surgeon, and we know that surgery is the only cure for pancreatic cancer. And Black Americans are offered this option less than other racial groups in the United States. For context of the impact of these barriers, the age-adjusted incidence rate is 15.9 versus 13.4 per 100,000 for Black Americans and white Americans, respectively. And the age-adjusted mortality for Black Americans is 13.3 per 100,000 people and 11 per 100,000 for white Americans. All of this data together points to vast inconsistencies for the care of Black patients at risk for and with a pancreatic cancer diagnosis. We'll learn more about this from our panelists later on. Our first guest is Dr. Summer Bizzurro. Dr. Summer Bizzurro serves as IPG Health's Chief Medical Officer, elevating the network's unmatched expertise in medical strategy. Dr. Bizzurro holds a PhD in cell growth and cancer from the University of Pennsylvania Medical School, a BS Research Intensive in Molecular Biology from Yale University, and was a postdoctoral research fellow with Memorial Sloan Kettering Cancer Center. Dr. Bizzurro is a member of ASCO and serves on the Lustgarten Board of Directors. Welcome, Dr. Bizzurro.
Thank you, Linda. It's wonderful to be here.
Dr. Bizzurro, increasing participation rates among Black Americans in clinical trials is key to advancing the science for all of us. And I know that you'll be providing evidence to support this. Can you talk a little bit about why you believe that clinical trials are so important in advocating for health equity?
Absolutely. So clinical trials are a gateway to the most innovative treatment options that we may have for different disease states. In oncology, a clinical trial, like patients will either receive the current standard of care or a new treatment under investigation. That treatment may be a novel mechanism of action. It may be an improvement on an existing mechanism of action that we already have, or it may bring together several products in a new combination treatment. For many people, this is their opportunity to receive potentially life-saving therapy. And it's also the opportunity to determine how a new treatment will perform in different types of people. If certain populations are excluded, then they miss out on this level of innovation. And the community, and when I say community, I mean both the medical community and the community the person belongs to, misses out on knowing how the treatment might perform in that particular population. So what side effects might they experience? How does efficacy look in that particular population? And that prevents us from being able to determine how we might be able to support these patients. If I could share my screen, Linda.
Great, thank you.
I'll elaborate on this.
This is great. This is really excellent. Thanks.
Sure. So, if you can see my screen, here at IPG Health, we started the Trial for Clinical Equality. We started this campaign in 2020 because we firmly believe that everyone should have access to the innovation that a clinical trial brings. And for us, it's not only a moral issue, it is, but it's also a scientific issue. So it's both of these things in one, right? No one should be denied. And we are generalizing results that are not based on the entire population. And we launched this campaign in 2020, and it was a perfect time in that that's when globally we were dealing with the COVID pandemic, the height of it. And we were also dealing with a lot of social justice issues. And so you can see there's a juxtaposition of both of those two aspects. And I'd like to just share the campaign video with you that shows, how we describe this problem. Okay, so you can see from that video our passion at IPG Health for this issue and making sure that, everyone has the access that they deserve.
That was great, Dr. Pizzurro. How do we know that oncology clinical trials are excluding different groups?
Sure. So in 2019, Jonathan Laurie and colleagues published a really great study in JAMA Oncology entitled Disparity of Race Reporting and Representation in Clinical Trials Leading to Cancer Drug Approvals from 2008-2018. So in total, this body of work looked at 230 trials. And in this work, they showed two important things that are currently happening. One, there's a lack of data transparency, and two, there's a lack of inclusion of Black and Hispanic patients in clinical trials. This is huge considering the amount of innovation that oncology has experienced in the last 10 to 15 years. When it comes to the lack of data transparency, race was only reported in 63% of the studies as just a baseline characteristic. So there were no subgroup analyses conducted in these trials, while 36.9% of the studies had no mention at all. So right off the bat, we're not exposed to what's actually happened. There's a lack of transparency with the reporting of the data. Now, when it comes to inclusion, compared to Caucasians, Black and Hispanic patients were underrepresented in most clinical trials for many different tumor types. And that, of course, included pancreatic cancer patients. So when you look at the problem, underrepresentation can be measured in two ways. We can compare the percentage of Black patients, for example, enrolled in pancreatic cancer trials to the percentage of Black people in the general population. And that's one way to measure underrepresentation. We can also compare the percentage in clinical trials to the percentage of Black people who are actually diagnosed with and die from pancreatic cancer. And the latter is certainly more powerful. It's a truer comparison. But by either measure, Black people are underrepresented in clinical trials. And, that's because there's certain barriers. And this study certainly found that there was a disconnect between the incidence and mortality rates of Black patients with pancreatic cancer and those who were included in clinical trials. They were not represented in the clinical trials that this group of authors looked at.
So what are some of those barriers? Because as you said before, it's a moral issue, but it's also an issue to the fact that we're not getting great results in these clinical trials because of the lack of diversity. So those barriers are important that we talk about them.
Right, absolutely. So before I go into the barriers, I just want to make one point that diversifying clinical trials helps to identify new biological processes that in turn leads to discoveries for all populations, right? So for example, the discovery of a protein called protoprotein convertase subcystillin connexin type 9, PCSK9. Okay. It's really transformed our understanding of cholesterol homeostasis and led to development of many important therapeutics. This protein was discovered while examining differences in cholesterol metabolism in a study that was specifically designed to investigate variation and a study that included Black subjects. So they found that Black subjects had mutations that were rare amongst Caucasian people, and therefore PCSK9 became a target for new exploration. Had that diversity not been included in that study, we would not have the 2 FDA-approved medications that limit the actions of PCSK9 because of that. So I just want to make the point that diversity lifts all boats and helps us all. So now I'll get into the discussion about, some of the specific barriers when it comes to helping people. So the first thing is the people, right? Lives are not lived in isolation. So when an individual is denied access to a clinical trial, they are denied that access to innovation. But there's also the potential effects on their family, their community, what they would contribute to our overall society, their productivity, that is completely lost. So there's the absolute burden on the people that we see. In addition to that, hopefully the example I just gave about the cholesterol example, there's also an example, the effect on scientific innovation. If we are only looking at things through a lens that is narrow, we are going to miss crucial information as a scientific and medical community. We are not going to be able to put those pieces together to help everyone. And so it has a definite effect on scientific innovation. And there's barriers there in terms of getting people into clinical trials, right? The cost, this is another barrier, right? So there is this idea that this is going to cost too much. We can't get people into clinical trials. There's this issue of people can have logistical barriers. They may not be able to meet the rigors of the clinical trial study. They may not be able to report to a site 3 days a week or every week. They may live very far away from an academic center. And so there is a cost to the human beings involved to that. But there's also a cost to the overall system when we don't diversify our clinical trials. So we are all taxpayers. We are all investing in our overall healthcare system, right? The cost of getting it wrong for not being inclusive and the continued comorbidities that go with it are huge. There's a cost to us as individuals. There's a cost to our government. There's a cost to those who are investing in clinical trials. Everyone is paying the price. Finally, another barrier, public trust, right? We saw that during the pandemic. If we are not inclusive when we study how treatments work and show that everyone is represented, then if I go to say, oh, you should try this product, Linda, well, I don't see myself represented in this clinical trial. Now we have a problem, right? So these are some, 4 big categories that discuss some of the burden that is felt and some of the barriers to getting people in clinical trials.
Dr. Becerra, what have you, if you were to say the most important thing we need to do to diversify clinical trials, what would you say the 2 most important things are?
I would say number 1 is to stop working in silos. These are not secrets, these things that I've shared with you today. There are many people who know about them and are trying to work in a silo to get things done. But I think there needs to be more coming together, healthcare professionals. I think the public needs to also demand change. And so not working at cross purposes with each other and working together to come together to solve the problems is really one of the number 1 things. And I think also there are people who are doing the right things. There are clinical trial sponsors who are getting it right, but we're not talking about what's working either. If we were more vocal about the things that are working, then they could be adopted by other clinical trial sponsors and we can spread the word there. The FDA certainly has guidance on how clinical trial sponsors can diversify their trials, but we need to be more vocal about this is working, this isn't working. Let's focus on what's working. Let's spread the word so that we're all working together.
I think those are really good points. And the lead grants that we'll be discussing later in this webinar are working to identify and remove these barriers to clinical trials. It's something that's very important to the Lustgarten Foundation. And as the lead funder of pancreas cancer across the United States, we know how important this is. And it's our commitment to ensure that trials are as diverse as possible. Pancreatic cancer is such a complex problem, and not diversifying these trials is not going to get us to where we want to be, which is transforming pancreatic cancer into a curable disease. So thank you so much, Dr. Becerra, for participating in this webinar. We know you're passionate about this, and we're really, really grateful to you. Thank you.
My pleasure. Thank you very much.
It's now my great pleasure to introduce the newest member of the Lustgarten research team, Jacqueline Lyman, our head of clinical research and development. Before joining Lustgarten, Jacqueline spearheaded pancreatic efforts for the Parker Institute for Cancer Immunotherapy. Before that, she worked at Memorial Sloan Kettering Cancer Center, where she managed the breast cancer trials team, built infrastructure to support investigator-initiated multi-center trials, as well as navigated institution-level research pilots and care improvement initiatives. Jacqueline holds a Master's of Integrated Immunology from the University of Oxford and a Bachelor's of Molecular Biology from Goucher College. Welcome, Jacqueline.
Thank you very much, Linda. It's great to be a part of the team, and thanks for the introduction. In turn, I would love to introduce our next guest, Dr. Rebecca Snyder. Dr. Snyder is an associate professor in the departments of Surgical Oncology and Health Services Research at the University of Texas MD Anderson Cancer Center. Her clinical practice is focused on caring for patients with pancreatic cancer, and her research efforts concentrate on clinical trials as well as cancer care delivery, specifically disparities related to race and social determinants of health. Dr. Snyder is actively involved in the National Clinical Trials Network Alliance for Clinical Trials in Oncology Cooperative Group, serving as the co-chair of the Gastrointestinal Surgery Working Group and liaison to the Health Disparities in Cancer Care Delivery Research Committees. Dr. Snyder is also our 2013 LustGarten Equity, Accessibility, and Diversity Grant recipient, which Linda will talk about a little bit more shortly.
Thank you, Jacqueline. I really appreciate the opportunity to be a part of this panel today. And what I hope to share with everyone in the next few minutes is a program that we're beginning at MD Anderson that's supported by the LustGarten Foundation to increase the diversity of clinical trial accrual in our pancreatic cancer clinical trial program. I have no financial disclosures or conflicts of interest. So we know that there are a number of barriers to clinical trial enrollment, and these occur on multiple levels. So they can occur on the patient level, clinician level, the system level, or even in how we design and conduct trials. On the patient level, oftentimes patients can't potentially afford extra visits and the transportation that would be required to get to those visits. Sometimes patients aren't aware that clinical trials exist or what their purpose is. Additionally, clinicians don't always have access to clinical trials, and so depending on the location and the center level, some clinicians are not able to offer clinical trials in certain communities. And then we've learned that there can be bias in how clinicians communicate with patients, and this can be exacerbated when the patients and physicians are of a different racial background. Several studies have shown that research staff don't always approach patients similarly, so there can be some implicit bias in how staff anticipate that patients would or would not participate in a trial. Additionally, on the system level, hospital systems or cancer centers are not always tracking the data and may not be aware that they're not accruing patients at kind of equal proportions, or as those proportions might be represented in their patient population. And oftentimes we've learned that we could do a better job of engaging community centers and community leaders to really help promote and educate the population of patients with cancer or who are undergoing cancer screening about the opportunity to participate in clinical trials. And then finally, we've learned that even the eligibility criteria, the medical eligibility requirements for participating in clinical trials can sort of systematically be biased against certain patient populations where some diseases may be more prevalent, and so they may be excluded at higher rates. So one of the things that I think is really important to acknowledge also is that there have been some historical inequities in medical research in the United States that have resulted in some general mistrust for good reason. And so many of you may be aware that for about a 40-year period from the 1930s to 1970s, the US Public Service conducted a study of patients who were Black patients, Black men in Tuskegee, Alabama. And these patients had syphilis and were not offered medical therapy. The purpose of this study was to examine and understand the natural history of the disease. But medical therapy was withheld from these patients, not to their knowledge. And when this was exposed to the media in the 1970s, this really resulted in significant distrust of the medical community by African-American patients in the United States. Many of you may have also heard of Henrietta Lacks. There was a recent book that was published about this, which I'd highly recommend that you read. But Henrietta Lacks was a woman who grew up in a family of tobacco farmers in Virginia and developed cervical cancer at a very young age, at age 30. And when she went to Johns Hopkins for treatment, she saw an OBGYN who took a sample of the cervical cancer cells. And then these cells were removed, not to her knowledge or her family's, and then they were shared with the scientist who then was able to use these cells as the first cells to be able to be cultured in media. And so then those cells were used to test a variety of vaccines and other drugs, and are responsible really for some of the most tremendous medical advances, including the polio vaccine and including testing of the COVID vaccine. But she and her family were unaware that the cells were being used for this purpose. And so taken together, these events have resulted in some mistrust, particularly among Black Americans, about the intentions of the medical profession and about clinical research, including the possibility of experimentation or randomization. I also think it's important that we talk about the structural barriers that can impact clinical care and clinical trial enrollment. And this is termed systemic racism. And so this really describes kind of like the system, the medical system, as well as kind of the general community, political, social system we have in this country that systematically can bias towards worse health outcomes in certain populations. And so this can, in the context of looking at cancer and clinical trials, this can manifest as inequities in the quality of hospitals that patients have access to. They may not have access, for example, in pancreas cancer, to be able to seek a surgical opinion and even surgical therapy at a high volume institution, which we do know is very important for optimal outcomes in pancreatic cancer. Patients may not have access to subspecialty physicians that are within driving distance for them. Sometimes we have seen that there can be differential treatment that is offered due to implicit bias about patient compliance or affordability. And in addition, patients face different social risks. So that can include limited access to healthy food or lack of green space for exercise. And then additionally, kind of important to what we're talking about today is that there may not be accessible clinical trials in a patient's community. And so patients would be, in order to participate, would need to drive a significant distance and may not have the financial means to do so or the insurance coverage to do that. But I think that there's, although kind of historically, the assumption has been that the reason that we see disparities in the proportion of patients that participate in clinical trials is because of this history of mistrust and kind of lack of willingness to participate. But actually, there's been some recent studies, including one that I'm going to describe here, that have shown that actually when patients are offered the opportunity to participate in a trial, actually they do so at similar rates, regardless of racial background. So this was a large analysis that looked at over 35 trials, including both treatment trials and cancer control trials. And they looked at data about patients who were offered to participate and what proportion actually chose to participate. And in this paper, they demonstrated that actually out of all the patients offered to participate, approximately 55% of patients agreed to enroll on a trial, and there was no difference by race. So despite kind of knowing that we have this history of inequities in our research and reason for mistrust, actually, when we approach and counsel patients about clinical trials, we see that patients are willing and interested in participating. And so this may actually be one of the biggest barriers, is providing accessible trials and actually approaching and offering clinical trials in a meaningful way to patients. So why is it important that we have diverse participation in clinical trials? Well, I think this is kind of boiled down really well in this paper that was published in the New England Journal of Medicine this year. And they really highlight that there's three main reasons why diversity in clinical trials is important. The first is that we know that clinical trials generate critical knowledge. And we want this knowledge to be generalizable to the entire population in the US, not just to a very specific or focused population that may have been the ones that actually participated in the trial. And so the only way to know that our treatments are effective, or to know if there are differences in the efficacy or the safety or toxicity, or to test these treatments in multiple populations. And so to be able to look at the population in general, but as well to look at subgroups and understand if maybe one therapy that might work well in one population may or may not work well in another population. We also, I think, can all agree that participation in clinical trials can build trust in medical research and institutions. So, by demonstrating that we are providing high quality care, that clinical trials can offer benefit to patients, and that we can do so in a transparent and equitable way, can really try to rebuild that trust in our profession and in our research environments. And then finally, it promotes fairness for participants and communities, and that applies to both the risks of participating in a trial as well as the potential benefits. So, in pancreas cancer, for example, as well as most cancers, really the best treatment that is recommended is to be a part of a clinical trial. Those are trials that are offering the newest and most advanced potential therapies. And so we want that to be offered equitably across populations. I'll spend one more minute reviewing, one of the things that we've seen in pancreas cancer is as our therapies are becoming more and more tailored, we're learning more about the molecular profile of tumors and how we can target therapies specifically to those molecular profiles. It's really important that we're enrolling patients from a variety of racial and ethnic backgrounds, because the molecular profile may differ by race or ethnicity. This was a study that looked at 90 clinical trials of nearly 6,000 participants, and these were trials that were specifically focused on precision oncology study questions. And as you can see here, actually the white participants were overrepresented in all studies. So as you can see, this first figure A, is showing kind of the observed to expected ratio of white participants to their representation in the population. And then when you look at each of the others, you can see that the other minority races are significantly underrepresented on trials. And when we look by cancer type, including the four most common cancers, breast, colorectal, lung, and prostate, Black patients were significantly underrepresented in each of those. And so we believe the same thing to be true in pancreas. And so as we're working towards identifying novel therapies that are specific and relevant to particular molecular subtypes of these tumors, it's really important that we're enrolling patients of all racial and ethnic backgrounds. So I want to transition now to tell you a little bit about some of the program that we're embarking upon at MD Anderson. We have a very active and robust pancreatic cancer clinical trial program. So we currently have 31 active clinical trial protocols, and this covers the entire spectrum of disease, everything from localized resectable pancreatic cancer, which is predominantly what I treat, to unresectable, locally advanced pancreatic cancer, as well as metastatic cancers, including first and second line therapy, as well as trials on investigating agents in patients who have been refractory to therapy, as well as phase 1 trials, which are kind of the first in human trials to test therapies that have never been used before. And so we've had a historical pretty a significant enrollment in our clinical trials program, but we've noticed that we could do better in terms of how we're enrolling by our patient demographics. And so what we have proposed and are fortunate to have the support of Lustgarten to do is a 3-part intervention. And it's really quite simple. It's going to seem pretty straightforward. But what we are proposing to do is to centralize our eligibility screening. So in most centers and at our center, when we have this many trials, each trial has a sort of study team and coordinator that is reviewing the clinical record to identify patients who may be eligible, and often relies on physicians or other members of the clinical team to identify that a patient may be eligible. But we're going to try to centralize that and do a kind of more streamlined and structured screening process that will include both some natural language processing software, which is basically where it's artificial intelligence kind of, where that we'll be able to use software that will review the medical record and identify whether patients meet or don't meet eligibility criteria. And then we're also going to have dedicated research staff that are going to specifically screen patients that are underrepresented in our trials to see if those patients would be eligible to participate. The second aspect of our proposal is that we plan to start screening patients routinely for social determinants of health. And so to understand, do patients have social needs that would potentially prevent them from participating, potentially financial needs or social support needs that we could address that would then potentially enable them to participate. And then we're also going to integrate some patient navigation, and that will include some specific education with patients about what are clinical trials, what does it mean to participate, what is randomization, and hopefully to overcome any potential mistrust or concerns about the clinical trial intent or process. And so our goal with this is to increase the number of patients who we can enroll on pancreatic cancer clinical trials here at MD Anderson, and then to specifically increase enrollment and retention of Black and Hispanic patients. And then our hope is that if we can demonstrate that this is effective in our center, that this could be something that we could implement more broadly at other sites. And this just kind of shows how we would potentially be implementing this program. So doing this sort of software review of patients, and then also doing a manual review of patients as well. And then kind of keeping track of patients who maybe aren't initially eligible so that we could potentially include them in the future as their disease may change. And then obviously this really key piece of screening for social determinants of health and intervening when we identify a need by involving our social work team, providing patient education and counseling. And then I think kind of one of the most important things is making sure that the whole research team here is receiving kind of ongoing feedback about how we're doing, so that this is always something that is on everybody's mind and that we're intentionally working towards making improvements. So that's all the content that I wanted to cover today. Again, really appreciate being here with all the other panelists and the opportunity to share this with you all, and especially the Lustgarten Foundation for supporting these efforts. Thank you.
Thank you, Dr. Snyder. You know, this is very important work, and I'm really glad that we can help support you in your efforts towards resolving some of these issues. It's really nice to hear that the lack of trust and comfortability in, the healthcare system at large, but also within clinical research, is slowly getting repaired, and something we need to continue putting our best foot forward on. Also ensuring that we're really enrolling a diversity of patients to all of our clinical trials with the goal in mind of developing therapies specifically for those patients and really understanding what that means on a molecular level as well. Before I invite Linda back to talk a little bit more about the LEAD program, I'm wondering if you could give us some insight on initiatives that you feel are going really well outside of the work that you're doing, and likewise where there are some gaps still in the field that we need to throw our weight behind, both from a pancreatic cancer perspective, but also a clinical research perspective as well.
Sure. I mean, I think that, I think one thing that we really need to address is not placing the blame or the burden on the patient as I showed, we know that patients are willing to participate when they are offered. And so I think that there is a great deal of work that can be done to address the implicit bias that exists on the, kind of research side. And implicit bias, just as the definition means, it's not something necessarily that someone is aware of, but it may be assumptions that are made or kind of subconscious changes in behavior that people may make without even realizing they're doing that. And so I think that implementing some structured education and training for our research teams is really important. ASCO has recently put forward some training and demonstrated that was beneficial or feasible in the community cancer center setting. And so I think that will be really important. And then I think accessibility is one of the major issues, and we've got to do something about ensuring that patients from communities where they may not have access to a large cancer center like MD Anderson can still access clinical trials. And so, I think the NCORE, which is the branch of the NCI, the National Community Oncology Research Program, has done an excellent job of trying to get these trials into communities closer to patients. But I think that's still one of the biggest hurdles. And so, we have to make it more accessible to patients, and then also try to provide some of that sort of pragmatic, structural support, so that if the barrier is, travel, if the barrier is time off of work for their caregiver to bring them, that we're able to provide some resources to really help support them to participate, because we all benefit. The more patients that participate, the faster that studies can be completed, and we're able to generate, evidence to support new therapies that benefit everyone with pancreas cancer. And so I think, that these things are really key to address.
We certainly agree. Thank you, Dr. Snyder, very much for sharing all of that with us.
Thanks, Jacqueline.
Welcome back, Linda. So as you noted, the LustGarten Foundation has committed significant resources towards addressing a lot of these issues, specifically around the LEAD program. So I'm wondering if you can share a little bit more on the LEAD program and give us some updates.
Great, sure. We are so proud of the LEAD program and really happy to talk about our first grant. So the LustGarten Foundation's inaugural LEAD grant, and LEAD stands for Lustgarten Equity, Accessibility, and Diversity. And as we just heard from Dr. Snyder, this program seeks to broaden inclusivity in the recruitment and retention of patients from underrepresented minority groups in pancreatic cancer clinical trials. The first grant was awarded last year to Dr. Jen Ye, Professor and Vice Chair of Research Surgery, Division of Oncology Professor at the Lineberger Comprehensive Cancer Center. The PROCLAIM study, which stands for Promoting Clinical Trial Engagement for Pancreatic Cancer, focuses on breaking down barriers to recruiting African Americans by addressing distrust, poor communication, racial bias, and culturally discordant clinical trial materials via a mobile health technology initiative. The Mobile Health Technology Initiative will be used as an educational and communication tool, fostering open discussion between Black people with pancreatic cancer and their cancer teams, ultimately increasing clinical trial participation. And we should have preliminary results to share next month.
Great, thank you, Linda.
Mm-hmm.
I will now introduce our final speaker of the day, Dr. Chika Madhu. Dr. Madhu is the Chair of Radiation Oncology for the Staten Island University Hospital. In her role, she oversees all radiation oncology clinical care, research, and training programs. After receiving her medical degree from the University of Michigan Medical School, Dr. Madhu completed her residency in radiation oncology at the University of Pennsylvania. She is currently an assistant professor of radiation medicine at the Donald and Barbara Zucker School of Medicine at Hofstra, Northwell. Throughout her career, Dr. Madhu has focused on multidisciplinary clinical care, as well as patient safety, quality improvement, diversity, and inclusion. She is chair of the Commission on Cancer at Staten Island University Hospital, and nationally, she holds a leadership position in the American Society for Radiation Oncology's Health, Equity, Diversity, and Inclusion Council, where she serves as Vice Chair of the Advocacy Committee aimed at eliminating barriers to minority enrollment in clinical trials and cancer screening. Welcome, Dr. Madhu.
So thank you again for having me, just to be here to talk about pancreatic cancer and how it affects our community. In my role as chair of radiation oncology, our goal is to try to make sure that everyone gets equitable care in cancer treatment, whether it's pancreatic cancer or any other cancer that they're diagnosed with. Just to kind of go over a few things, and thank you, Dr. Snyder, for really shedding a light on barriers to access of medical care. I think here at Northwell, we've been, trying to work very hard at making sure that all of our patients, have access to medical care. So for pancreatic cancer, if we take a step back, nationally, the incidence of pancreatic cancer is about 13%, 14% or so per year, for most patients. And in the state of New York, that seems to be true, and it also holds true in Richmond County, Staten Island. So we probably expect about 64,000 cases of pancreatic cancer diagnosis sometime this year, and unfortunately about 50,000 deaths this year from pancreatic cancer. That's a very sobering statistic. And our goal is to make sure that our patients have the care they need right when they need it, and we're able to get them onto clinical trials as soon as possible. So this first slide really shows sort of the landscape of Staten Island. And all of the dots that you see on there are where all of our ambulatory services are located on Staten Island. And our goal is to make sure that we are in the places where our patients are so that we can meet their needs. So with regard to access, there are different aspects of access. Is there a physician near you that you can conveniently get to? And I think we're doing a pretty good job of making sure that we are there. Now, the other part of access is, okay, now there's a physician's office next to you. Can you be seen there? Are you insured? So this is just a schematic of race, ethnicity on Staten Island, average income on Staten Island, and insurance coverage. So I think on Staten Island, we do a pretty good job of making sure that patients are insured, whether it be commercial insurance, Medicare, Medicaid. We only have about 6% uninsured patients, but that's a big number. And when those patients are diagnosed with pancreatic cancer, how are they going to get treated? Our goal at Northwell is to make sure that any patient who walks through our doors with a life-threatening diagnosis like cancer will get treated. Our goal is to make sure that we have a multidisciplinary team involved to make sure that social work is involved to make sure we get the patient the coverage that they need. Another aspect of access is transportation. Are you able to get to where you need to get to for your cancer treatment? We are blessed in New York because we have a robust public transportation system. People take the bus, train, or drive. The traffic is a different story. That's a whole other show. But people can get to where they need to get to. But the question is, do you need to travel so far to be able to get your treatment? If you think back to the patients who are undergoing treatment, they're tired. They're getting chemo. They're getting radiation. They just had surgery. And do we want those patients and their caregivers traveling so far out to be able to get treatment? So another thing we're doing at Northwell is we have an excellent collaboration with our Northwell Cancer Institute as a whole and Cold Spring Harbor Laboratory. And the goal is to make sure that we have innovative transitional clinical research going on, and we're able to push out those discoveries to all of our cancer centers. Our pledge to our patients is to make sure that whether a patient is in Westchester County, or if they're in Queens, or if they're in Manhattan, or in Staten Island, or in Long Island, they're getting the same care. And that's important for access for our patients, like Dr. Snyder said, if you do not have access to the latest and greatest clinical trials or the latest and greatest technology, then that's really not health equity. So our goal is to make sure that every single network site that we have, we are all collaborating with each other, collaborating with the Cancer Institute as a whole and Cold Spring Laboratory to make sure that clinical research is at the forefront of care. So one of the exciting things that's coming to Staten Island is that we are in the finishing phases of completing the Florina Cancer Center. And what this is going to bring to the patients in our community is a world-class cancer center where you get to see all of your cancer physicians and your cancer support team members in one building. So when you come in, you have access to surgical oncology, medical oncology, radiation oncology. The adult and pediatric infusion services are also in the same building. Patient navigation is key. It is very easy to get lost in the process of getting treated for cancer. Which test am I getting done today? Which biopsy am I getting done today? Which doctor am I seeing? Every patient is assigned a patient navigator to make sure that they are able to get to where they need to go to, and they're getting all the care that they need. Clinical trials is key. So we have several clinical trials within the Cancer Institute as a whole to make sure that patients have access, whether it be clinical trials that's focusing on different technologies or immunotherapy or doing systemic therapy before surgery versus after surgery. This is key in making sure that all patients have equitable care wherever they live. And also our supportive services. So we have nutrition services, we have social work, and we have integrative medicine as well. This world is really too fast, I have to say. And I think when someone's diagnosed with cancer and you have to do the surgery, the radiation, the chemo, and everything in between, and then there's still life that you have to take care of, sometimes it's important to just sort of take a moment and just sort of be silent. We will have a dedicated space for patients to be able to do yoga, to be able to do acupuncture, Tai Chi, or just silence, meditation, whatever it is. But this is our goal, to be able to offer these things to a patient. So, with regard to multidisciplinarity, I think in pancreatic cancer, it's, very complicated disease that requires input from all of these specialties. And it's important that when you have access to care and you get there, that you're actually getting multidisciplinary care. And that means having the input of physicians from, radiology to pathology, surgical oncology, rad-onc, med-onc, your GI doctors, for long-term follow-up, as well as nurse navigators, as we talked about. And, for our department in the radiation oncology world, what we do in our part to make sure that the patient's getting, high standard of care is to make sure that we have the latest technology available for the patient. So we have external beam radiation therapy. We offer SBRT, so that's stereotactic body radiation therapy. And that's really pinpoint radiation beams that are coming from different angles, but really focusing on that tumor and being able to reduce those or mitigate those to all the other organs in the area, as well as all the other services that we offer. And we do this at all of our sites to make sure that wherever a patient goes within Northwell, they have the same quality of services. So this is a brief schematic of what happens, in radiation for pancreatic cancer. Now, not everyone is eligible for this. This is in a patient who has a very early stage pancreatic cancer. So here you see where the tumor is, and you see the bowel in the area, you see kidneys, and you see the spine. And our goal with SBRT is in select patients who have very small tumors, we're able to really target that tumor with pinpoint beams and reduce dose to the surrounding organs for the patients. And we have clinical trials that involve this sort of technology but it's really important, nationwide and wherever we are, to make sure that we are able to give access to patients to make sure that we attain health equity for everyone. And I think those are my slides. Stop sharing.
Thank you, Dr. Madhu. That was really fantastic. And, I think highlights, as you just said, a really important point that we need to be thinking nationally, but also starting locally in terms of how we can leverage existing infrastructure and really supporting local communities and ensuring that the care that they receive is holistic and equitable on all accounts. So thank you very much for speaking on this today. And before I'll pass it back to Linda, I wanted to ask you the same question I asked Dr. Snyder. In the past few years, there has been an increased amount of attention placed on healthcare inequities and clinical trial enrollment diversity. And I'm wondering if there are initiatives out there that you think are going really well, and likewise, where there are still gaps we need to fill, both from a pancreatic cancer care perspective, but also a clinical research perspective as well.
Excellent question. So, as you mentioned earlier, part of my role within ASCO, which is the American Society for Radiation Oncology, is really I'm an advocate. I work on the advocacy committee to make sure that we get health equity with regard to enrolling patients in clinical trials and also for cancer screening. And in the past year and a half or so, we've been working with NRG Oncology, which is a big research institute that does a lot of oncology research. And part of our goal is really to look at things globally. First, we talk about access. If we work on that and make sure that patients get to where they need to go, then the other things we need to talk about is, can we enroll patients equitably in clinical trials? And what are the reasons why we can't? We've been looking at clinical trial design. So how are those cancer studies, the clinical trials being designed? And are there things in the clinical trial design that are, perhaps, not really meant to exclude a certain group of population, but eventually that's really what it does. So we're coming back and looking at what are the eligibility criteria or the ineligibility criteria. If you want to design a clinical trial with, clean, perfect kidney function and clean, perfect, blood sugar, so no diabetes, that's great. However, what is the population that we're treating? And what population has a higher risk of having uncontrolled high blood pressure, uncontrolled diabetes, and kidney disease? So when you create those restrictions, that population is not going to be able to be enrolled in those clinical trials. So what we've been working with NRG Oncology and they've been really great at this. They have the Health Disparities Committee as well that's been working on this, is to make sure that at the conception of clinical trials, at the initial design, make sure that we have a DEI lens on the structure of that clinical trial to make sure that we're not inadvertently excluding certain parts of the population. As Dr. Snyder mentioned, implicit bias, right? So if there are certain assumptions and presumptions about certain parts of the population, you're not going to offer those clinical trials to those patients. Another thing that we all have to work on as a country globally is workforce diversity, right? So a patient may respond to me a little bit differently versus Dr. Snyder or versus another physician. But if you have that workforce diversity, right? So workforce diversity in your clinical trial management office, in just your clinic even, whether it be physicians, whether it be residents, there's still a lot of work to be done there, but certainly something that we need to work on as a group. And then also, just making sure that we're getting training on implicit bias. ASCO's got a great program going, and I think it's important for all cancer center directors to sort of take the lead on that and make sure that all of your physicians, all of your clinical trial managers have undergone some sort of implicit bias training. That way we can be able to take care of patients a little bit better. So I think, things will get better. It's just hard work. it's hard work, and it's not going to get better overnight. You just have to keep pushing to be able to get the work done. But the patients want to be enrolled in clinical trials, and I think sometimes clinical trials will give us some answers, whether or not a certain population will do better with a certain kind of treatment versus a different kind of treatment, and we need to have those questions answered.
Wonderful. Thank you very, very much for being here and for sharing this with us today.
No problem.
And with that, I will pass it back to Linda for some final comments and remarks.
Thanks, Jacqueline, and thanks to Dr. Madhu and to Dr. Snyder. These conversations are so important. We know that pancreatic cancer is such a complicated cancer, and we know that access to trials for all patients is so important. And without the physicians like Dr. Matt Madhu and Dr. Snyder really thinking about solutions for these issues, we're not going to be able to solve them. So I'm so pleased that we were able to present this very informative conversation today. The Lustgarten Foundation is so honored and proud to highlight our commitment that we've made to equity, diversity, and inclusion in pancreatic cancer research. And we hope that all of you leave today's session with a better understanding of why we are so committed to this important work. We hope that you'll complete the questionnaire that you'll receive after this webinar, and we look forward to welcoming you back to 3 new LustgartenLIVE symposiums this fall. I hope everyone on today's call took a moment to reflect on the significance of yesterday's national holiday of Juneteenth. So thank you all, and we'll see you in the fall.